Recording in progress.
Heavy workload. Hardly any private life. Lots of responsibility. Always pushed to the limit. Whenever I ask doctors and nurses why they take all of that on, they often say, because what I do has meaning. Meaning for the lives of others, and therefore for my own life as well. As a global forum for medical specialists, we asked ourselves, how can we most effectively support the work, ambition, and dedication of these individuals? We sought out dialogue. We listened, and we understood. With a supportive exchange among medical professionals who network their knowledge around the globe, so that they maintain their expertise at the highest level for their entire lives. With disciplinary approaches that promote specialization without losing the perspective on medicine as a whole. With smart, modular concepts that are compatible with the busy lives of medical practitioners and nurses. With offerings whose contents provide answers for the reality of everyday medical life. With a growing perspective on trends that enables medical practitioners to already prepare for future challenges today. In close dialogue with renowned specialist companies that bear testimony to the quality of the offers. With inspiring forms of learning that don't just convey knowledge, but make it an experience for the senses. And with innovative teaching methods that prepare you not just for tests, but for life. Nurses and care assistants, physicians and hospital managers, and the people who work in the home healthcare services sector. All of those who teach and learn at the Escalop Academy share a passion for excellent medicine and very high personal standards. We invite you to join in a dialogue about health and medical care. A dialogue that is dedicated to life.
Sharing knowledge, learning something new, gaining confidence, thinking medicine, improving health. This is what drives people at Escalop Academies all around the world. And this is why we communicate with one another in a dialogue that is dedicated to life.
All around the world, both speakers and participants, as well as researchers and practitioners, meet at Escalop Academies in order to think medicine further ahead. Is there anything more valuable than a dialogue dedicated to life?
The Escalop Academy connects people who want to know more, to improve medical care. They are looking for a dialogue. We offer a dialogue dedicated to life.
Dialogue dedicated to life.
对话致力于生命健康。
Diálogo dedicado a la vida.
Dialog посвященный жизни.
Dialog dedikasi bagi kehidupan.
Dialog dedykowany życiu.
Dialogue dedicated to life.
الحوار مكرسة للحياة.
Diálogo dedicado à vida.
Dialog pro život.
Become part of this international, interdisciplinary dialogue at Escalop Academies all around the world. A dialogue dedicated to life.
Good morning, everyone, and welcome to today's webinar, Improve Medication Safety with Smart Infusion Pumps Technology. I'm your moderator of the day today. My name is Bhuvaneswari Janakiraman. Teresa, yes, Clinical Application Manager from B. Brown Hospital Care Division, Asia Pacific. Now, I'm truly excited to introduce our speaker of the day today, Dr. Ravindran Rasyal. He is our consultant and an anesthesiologist consultant and critical care specialist from Avicenna Women's and Children's Specialist Hospital from Malaysia. Dr. Ravindran received his MBBS from Kasturba Medical College, Manipal in India in 1983. He did his master's in anesthesia from the University of Malaya in 1993. This is one of the oldest university in Malaysia. So I believe he has been very wise experience on anesthesia. He is also a fellow of Academy of Medicine Malaysia, FAMM, and a fellow of the Academy of Medicine Singapore, FAMS. His career in anesthesia began in the Department of Anesthesia in Ipoh Hospital, Perak, and subsequently in the University Hospital of Kuala Lumpur. He has been in private practices since 1994. He was a past president of the Malaysian Society of Anesthesiologists and past president of the College of Anesthesiologists Medicine of Malaysia. Now, let me go through our agenda of the day today. We have 15 minutes welcome and introduction session by me, 90 minutes of solid 90 minutes of reducing medication error, improve patient safety with smart infusion pumps and advanced technology presentation by Dr. Ravindran Rasia. We will have the first session 45 minutes, then followed by question and answer session, a second session of 45 minutes of presentation, and we will end with another 15 minutes of Q&A session, and we will do the closing. Before we get started, I would like to go over a few important messages and rules, in-house rules. First, this webinar will be recorded. Note that your microphone is muted throughout the session. Please post questions in Q&A box anytime throughout the webinar. We will collect all the questions and present to Dr. Ravi during our question and answer session. We will address all the questions as much as possible we can. This webinar is translated live to Vietnamese language, and I strongly believe that this is an added value for our webinar today. And there will be a link and passcode to generate e-certificate will be shared at the end of the session. Now let me briefly go through how to switch to Vietnamese language. At your right side, if you are a laptop or desktop user, please kindly follow the instruction at your right side. And if you are a mobile user, kindly follow the instruction in your left side. And you can also post any question if you have any inquiries. Our team will help to address it in chat column there. Now, smart pump technology is a very promising technology to prevent medication administration error. During this pandemic session, I believe that we are craving for some help to save costs and also time and with the quality care is provided to our patient. So without delaying, let me now pass the floor to Dr. Ravindran to present to us our presentation of the day today. Over to you, Dr. Ravindran.
Thank you, Bua, for the kind introduction. Yes. Okay. Good morning, everybody, and welcome to this webinar session. It's the first of a series. And I would like to thank BBRON Malaysia and S-Club Academy for inviting me to speak on this topic of how to improve medication safety with the smart infusion pumps. My name is Dr. Ravindran, and I am a consultant anesthesiologist at Avicenna Specialist Hospital and Avicenna Women's and Children's Hospital here in Shah Alam, Malaysia. I do not have any relevant financial relationship with commercial interest to disclose. The presentation, the layout for the presentation today, I will start with a bit of introduction, do some definition, as well as speak a bit on the MERS in Malaysia, following which I will go on to speak about types of medication errors, how do we manage these medication errors. Then we'll have a short break of a Q&A, and then the second part of the talk will be on smart pumps. We'll talk about our drug library, some safety strategies, and finally we will conclude. World Patient Safety Day is marked every year on the 17th of September. And this was established by the 72nd World Health Assembly in May 2019. This was following an adoption of Resolution WHA 72.6 on global action on patient safety. This resolution recognizes patient safety as a global health priority and promotes the objectives of World Patient Safety Day, namely to increase the public awareness and engagement and to enhance global understanding and spur global solidarity and action to progress patient safety. The World Health Organization estimates there is a 1 in 3 million risk of dying while traveling by an airplane. But in contrast, the risk of dying due to a preventable medical accident while receiving health care is estimated to be 1 in 300. So in fact, as many as 1 in every 10 patients is harmed while receiving hospital care in the high-income countries. The estimate by WHO, every year there are 134 million adverse events, which occurs in hospitals, especially in the low to and middle income countries, due to unsafe care. And this contributes to about 2.6 million deaths annually. I'll go a bit to the definitions. What is a medication error? A medication error is defined as any preventable event that may cause or lead to inappropriate medication use or patient harm while the medication is in the control of the healthcare professional, the patient, or consumer. This is according to the National Coordinating Council for Medication Error in the Reporting and Prevention. So a medication error may be related to professional practice, the healthcare product, the procedures, the systems, including the prescription, the communication, the labeling of the product, the packaging of the product, the nomenclature of the product, compounding, dispensing, distribution, administration, monitoring, and its use of the drug. So it's a whole range where a medication error can take place. What is medication safety? It's defined as the freedom from accidental injury due to medical care or medical errors during the medication use process. It deserves the same prioritization given the scope of medication use in a patient care and the frequency and severity of potential harm. What is an actual error? An actual error is a medication error which has occurred and it has reached the patient. If the error is detected by the patient, it is considered as an actual error. A near miss is a medication error that has a potential to cause an adverse event, means harm to the patient. But it did not reach the patient because of chance or because it was intercepted in the medication use process. So for example, if the healthcare personnel has detected and corrected the error before it reaches the patient, this is considered a near miss. So in Malaysia, a recent study on medication errors, which was reported to the National Medication Error Reporting System, showed that 98% of cases did not result in harmful effects. Similarly, other studies have reported that the majority of medication errors did not result in any harm to the patients. So the medication error reporting system, or in short called MERS, this is a national reporting system which is here in Malaysia, and I'm sure it is also available in most of the other countries. This was introduced by the Pharmaceutical Services Program of the Ministry of Health of Malaysia in 2009. It serves as a platform to encourage healthcare professionals to report any medication error which is encountered. It doesn't mean to be just doctors. It can be allied health personnel, nurses, administrators, anybody in the healthcare system can report a medication error. What are the guidelines? It describes the management of medication error and the step-by-step process of how to fill and submit the report to the medication error reporting system. Medication safety is one of the vital components in patient safety. But unfortunately, medication errors still occurs, and it can often go undetected. Some medication errors may result in serious patient morbidity and mortality. So if we have errors detected through an active management and an effective reporting system, which will disclose the medication error, we can learn from that and encourage safe practice of giving medication. So because of that, we have a medication error reporting system. As I mentioned, it was introduced in 2009 as a mechanism, tool, and a platform for monitoring medication errors at the national level. This reporting system will encourage all healthcare professionals to report any medication error which has been encountered in their system. In 2013, the MERS was upgraded to an online system to provide easier access to reporting and sharing the lesson learned from one incident that has happened. Now, the primary objective of this medication error reporting is to obtain information and maintain a database on the occurrence of all medication errors related to medication use in prescribing, dispensing, administration of the drug, monitoring, and other processes involved in the medication management system. Now, these reports, which are submitted through MERS, will be analyzed, and risk reduction establishment strategies will be developed to promote safe medication use. The findings from MERS will provide important knowledge which can be used as a guide in developing strategies, operating policies, and action plans to strengthen the current healthcare system. This system requires a collective effort from all parties and a change in the way of management of medication errors. We need to be able to discuss errors openly, encourage the reporting of errors, and maintain a culture that is non-punitive and blamelessness. We shouldn't be blaming for any healthcare professional which has a medication error has happened. In fact, we should learn from that medication error and do things to develop to make sure that error is never repeated again. All the reports which are submitted, there's confidentiality with regards to the identity of the patient as well as their healthcare professionals involved. So basically, it's just getting the data so that we can develop SOPs and various other things to make sure we do not have a lot of medication errors. So we'll do a poll question now. what do you think of how many writes you need to do to a patient to prevent medication error? So just give a few minutes for people to answer this poll.
Yeah, we have our first polling question here. So you're given like 30 seconds to answer. Just click on the option and press submit, and we will get the result. And I will inform you the result, Dr. Ravi. Here we go. We have the answer for our first full question. How many medication rights are followed in your respective country? We have an interesting answer here, Dr. Ravin.
Yes, I can see that.
Yeah,
42% has answered as they have got 10 medication, to 10 rights to do to make sure the correct medication is given. Okay.
Exactly.
Exactly. So let me go for now. Let me just go to the next slide. Right. From the MERS recommendation, we looked at only 6 rights. We have the right patient, the right drug, the right dosage, the right route of administration, the right time of administration, and the most important thing, the last one, was documentation of the medication. So in today's world of a lot of medical legal issues, documentation is very, very important. If you don't document, nobody knows what has been given to the patient, whether the right drug was given or the dosage, nothing is there in the patient's notes. So we need documentation to be done as soon as you have given a medication to a patient. I know sometimes some nurses, what they do is they give the medication to all the patients and they come back and then they sit down and just sign all the forms of 10 patients at a go, not as individual. We should actually create a culture where as soon as you give the medication, documentation should be done. Now we go on to another poll question. What is the most common error in giving medication?
Here we go, our second poll question. What is the most common medication error in administering medication? So we have 4 options here. The same method, just press your answer, click the submit button, and we will. Yeah, here we go, Dr. Ravi. We have.
Okay, I think a lot of answered as the wrong dose. 62% answered it was the wrong dose. You're not wrong, that's true too. Wrong patient, 3%. Wrong prescription, 23%. But we did a study, and the most common error was the use of abbreviations instead of the full name of the drug as in the prescription. So this is where the doctors come into play. They use short forms. I give you an example. Is in different languages, the symbols are different. Like here in Malaysia, the symbol for, the normal symbol we use for potassium is K+, right? And in Malay, calcium starts with the letter K. So people think, K is calcium and not potassium. So there's one example I'm giving you. So when doctors prescribe drugs, in some countries, the nurses are allowed to prescribe certain drugs, but the full name of the drug should be written in the prescription form. The drug name, the route of administration, the dosage of the drug, how many times a day the drug to be given has to be written on the prescription chart, signed by the doctor with his chalk, so that when it goes down to the pharmacy, they know what. It's a double check. The pharmacy, when he or she prescribes these drugs, prepares the drugs for the ward, checks if there's any error, they can immediately call the doctor to verify whether this is correct dosage the doctor is giving. This is even more important when we are giving drugs to the pediatric age group, because the dosages are so much different. We need to calculate according to the weight of the patient. So this is very, very important. So what are the types of medication errors? So as I mentioned, the prescribing of the drug is very, very important. Sometimes we omit certain medications from being written down in the prescription chart. So that is a no-no. You need to write every medication which you are giving to a patient. Certain drugs are supposed to be given 3 times a day, but it's written down. And sometimes you have given the start dose at, say, 9 o'clock in the morning, but the dose is every 6 hours. So the nurses will have it like, oh, we would like to give it normally 6:12, 6 p.m., 12 midnight, the drug. But we have given a dose at 9 a.m. And the nurse will give the second dose at 12 noon, because the system in the hospital is, if it's 6 hourly, it's 6:12, 6:12. If it's 3 times a day, it's 8, 4, 12. So in between, actually we have started the drug in between. So we have to make sure the timing is correct. The drug is given according to what it's supposed to be. The use of unauthorized drug on a patient. Dose calculation, improper dose, inaccurate dose, especially when we're doing pediatric cases, looking after pediatric patients, the dosage of the drug needs to be calculated well. Wrong dose is written down in the prescription, and the wrong dose is prepared by the pharmacist. So this has to be a check and balance. You have to write the correct dose. Even if you miss, the pharmacist who looks at the prescription must to make sure that it is the correct dose. If it's the wrong dose, must immediately contact the doctor who wrote the prescription to verify whether that's the correct dose the doctor wants to give. Then again, the errors of incorrect route of administration, giving the drug to the wrong patient, at the wrong rate if you're using a pump, or you might give in double the dose. So the number of errors and accidents at both the public hospital and the private hospital has increased in recent years, despite the efforts by the administrators of these healthcare centers to improve treatment safety. Between the years of 2016 and 2018, the reported medication errors into MERS jumped from 3,100 to 3,700 cases in just the 2 years. A lot of these incidences were attributed to ineffective communication, the lack of teamwork, overwork of staff, especially now with the COVID pandemic. We have staffs working long hours in PPE gear. They get fatigued very easily. And sometimes they fail to follow standard operating procedures and the use of shortcuts. So this is another avenue for medication error. When there's failure of the safety system, this will lead to the loss of the trust in the healthcare systems. So in 2003, the Patient Safety Council of Malaysia was established. And the function of this council was to outline the priority areas and benchmark patient safety performance in Malaysia. The prevalence of medication errors was found to be about 30% in the hospital, and the highest number of medication errors which was detected among patients was getting treatment in the red zone of the emergency department, followed by the yellow and the green zone. Most likely cause for this is because in the red zone, we are treating a patient, patient's life is at stake, we will be rapidly giving medications, there is no check and balance, somebody is giving medication, somebody is ordering the medication verbally, and that's where errors can take place. So, medication safety and to take extra precautionary steps is very important to prevent adverse reactions, overdoses, and death of the patient. So whether you are prescribing an opiate or an antibiotic, they should all follow the general steps towards medication safety. It doesn't mean that, oh, I'm prescribing an opiate, so I have to be very careful when I'm prescribing an opiate. But when I'm prescribing an antibiotic, yeah, that's okay. I don't follow the steps. There's no two ways about this. You should, every drug given must follow the same principles. First, you have to verify any medication order and make sure it's complete. Check the patient's medical record for any allergy or contraindication to the prescribed medication. In other words, for example, I will just prescribe, say, non-steroidal to be given to a patient without checking the notes. But in the notes, it's written the patient is allergic to non-steroidals. So we need to double check. Make sure the patient is not allergic or there's no contraindication to the drugs you're going to prescribe. Prepare medications for one patient at a time. Especially in the public hospitals, we have house officers preparing and giving IV medications to their patients. So sometimes what they do is they've got 5 patients under their care who needs to be given antibiotics. They prepare the antibiotics in the medication room at one go, and then they go from one patient to the other. This is prone for giving the wrong antibiotic to the wrong patient. So prepare medications for every patient at a time, one patient at a time. You need to educate the patients about their medications. This is from the doctors as well as pharmacists have to educate the patients when they dispense the medications to the patient. But there are certain medications which you can only take after food, and you need to advise patients about this. You need to advise patients, oh, you might have these side effects from the medication and what to do if you develop these side effects and so forth. And please follow the 6 rights of medication administration, which I mentioned earlier. That is the right patient, the right drug, the right dose, the right route of administration, the right time of the administration, and the documentation of the drugs. Medication errors can have very undesirable consequences to the patient, such as increasing the length of hospitalization, increasing the cost of hospitalization and healthcare. They might lead to disability as well as distrust in the healthcare system, may cause severe injury or even death to the patient. So how do we manage these medication errors? You report every medication error which has taken place. So you need to detect and report. Reportable events include both actual errors as well as near-miss errors. That means the errors that have been detected and corrected before they reach the patient, or errors which have been detected in accordance with the standard process and workflow of the healthcare facilities. So every error has to be reported, documented and reported. After you get these reports, you need to analyze these medication errors reports regularly. It is not just doctors and healthcare professionals report the incident. The person who is monitoring these reports must check on it regularly and investigate, analyze, and find the findings. Just because I've got the findings, I need to share this with all the staff. And you need to conduct a root cause analysis to identify why is there a root cause for this error and what action needs to be done to eliminate it. A simple example will be is like a needle stick injuries. It's a reportable event and you need to find what was the cause of it, why was there a needle stick injury, and what remedial action was taken to prevent such an injury from occurring again. And you need to share this with all the concerned staff as such. Next part is to how we want to establish an error preventive strategy. Each healthcare must establish a patient medication safety committee. And this committee should discuss all patient safety related issues. You need to implement an error prevention strategy that focuses on the system, design, and safe behavioral practices, and this has to be monitored continuously. Include medication safety checks in the ward checklist, in the pharmacy visit list, as well as when you audit your reports. And like I mentioned, once you have audited your reports, worked out a strategy how to prevent such errors from occurring again, you need to organize education and learning sessions to share all the medication errors and how you're going to prevent this from happening again, and you need to discuss this with all the staff concerned. There is no use you find everything and you know about it, but you do not dispense. There's no learning from this if you do not share it with your staff. Record and analyze all the drug selections, the preparation, labeling, and filing errors. Identify during routine checking process for quality improvement, especially if you want to establish policies, protocols, or guidelines to make the staff aware and to educate the staff. So it is an ongoing process. You need to continuously improve the program. Quality assurance is very, very important. And if you look at the JCI and the Malaysian Standards of Quality Health Care, this is one of the criteria they look into it, whether you have got policies in place, whether you're continuously upgrading your policy to prevent medication error. Adopt a just culture. What do you mean by a just culture? It's a model for shared accountability for safe system design and behavioral changes supported by high-level managements. A just culture encourages individuals to speak up and to report a medication error. And it allows for proper judgment of the medication error and provides learning opportunities to all healthcare professionals. An example of this, if you notice, say, one of the healthcare professionals has done a medication error and the medication error was not reported by the healthcare professional, and you know that has happened, you should speak up. You are not speaking up because you want to put that person into trouble or degrade the person, but what you're doing is you're reporting a medication error so that everybody can learn from that medication error. It is not a thing of finding fault with one person or finding fault with the management or finding fault with the system. If there's a problem with the system, there's a problem with the higher level management, because of that, or because of a policy, there was a medication error, it needs to be reported so that it can all be corrected and shared with everybody. There is visible commitment on patient safety goals within the organization. So each organization can have their own medication safety indicators and objectives in their plan. You should adopt a no-blame culture in your organization to manage medication error. People sometimes do not want to report a medication error because they are frightened that they will be blamed and punished for having their medication error. That culture should not be there. There must be good cooperation among hospital and facility units in order to work together to provide the best care for their patients. So the error outcome categories is divided from A to I. Now, what is category A? These are circumstances or events that have the capacity to cause an error. Example, your handwriting of your prescription, ineligible. You use abbreviations, or there's incorrect storage of medication, or there's mix-up of drugs. There are a lot of drugs which looks alike, especially the ampules. Like at one time in Malaysia, the adrenaline ampule and the atropine ampule was being bought by one manufacturer, and both looked almost identical. And if you want to give atropine, by mistake, you're opening up the adrenaline ampule. So we have to be careful. And when the healthcare professional tops up, they mix up the drug because both look almost the same, and the wordings are so small that the color looks the same, and they put the adrenaline ampule into the atropine ampule storage area. So these are events that can lead to cause an error. Harm is defined as temporary or permanent impairment of the physical, emotional, or psychological function or the structure of the body, and or pain resulting from requiring there must be some intervention to treat the harm. Category B is an error has occurred, but the error did not reach the patient. So, for example, the doctor prescribed a drug to be given 4 times a day, but the drug can only be given 3 times a day, but the error was detected before the drug was dispensed to the patient by the pharmacist. That comes under category B. Category C is an error which has occurred that has reached the patient but did not cause harm to the patient. This can be medication which reaches the patient and is administered to the patient but did not cause harm to the patient, but also includes medication which reaches the patient but it was not administered to the patient. For example, the pharmacist might dispense an incorrect medication to the ward. The nurse administers the incorrect medication to the patient, but there was no harm to the patient. Or the other situation is pharmacist dispense the medication to the patient, but the patient realized that the medication is incorrect and returns it back to the pharmacy. Category D is an error which has occurred that has reached the patient and requires monitoring to confirm that it resulted in no harm to the patient and doesn't require any intervention to preclude harm. Example is some other patient's profile was accidentally placed inside a patient's profile file, which has led to wrong medication prescribed during the visit. Category E is an error has occurred which may have contributed to or resulted in temporary harm to the patient and requires intervention. F is an error has occurred that may have contributed to or resulted in temporary harm to the patient and required initial or a prolonged hospitalization. Category G is an error has occurred that may have contributed to or resulted in permanent harm to the patient. And category H is required an intervention necessary to sustain the life of the patient. And category I is the error has contributed to or resulted in the death of the patient. So we'll take a short break now and pass over to Buwa to see any questions which we can answer for the first part of the.
Yes, thank you very much, Doctor, for the very interesting first session. We have a question here. The first question is, some medication is safe to give slowly. However, due to shortage of infusion pumps, there is tendency to administer as a slow bolus. Is this considered as a medication error?
No, if you don't have a pump and the drug is given, has to be given slowly, as long as you give it directly intravenously in a very slow fashion. Most of the drugs which need to be given slowly, it's usually you run over 1 or 2 minutes, so you can give it slowly. But there are certain drugs which you need to give through a pump, like if you're going to give potassium supplement, IV potassium to the patient, then you need to run it in a drip, and over a period of time, then you have to either use a pump or you have to calculate the drop rate so that you run that over a couple of hours. So it depends on what drug you're doing.
Okay, thank you so much for the answer, Doctor. We have a second question here. Was there errors reported due to transcribing error or due to verbal or phone order? What was the rate like? What will be the best recommendation to minimize this?
Okay, yes, a lot of doctors give verbal orders over the phone, especially in the intensive care and critical care units where the nurse might ring up in the middle of the night and say, doctor, there's no urine coming out, or the last hour there's only 10 mils of urine, and the doctor orders, okay, why don't you give furosemide 20 milligrams stat and we see the urine, whether it's coming out. Yes, you've given a verbal order, but when you come back into the hospital to see the patient, you need to document that order into the prescription chart, the dosage you are given. The nurse who is given the drug, she needs to document in her notes that you did a discussion and this was what the doctor said and this is what I had given. And it is always a good practice is when the doctor gives an order over the phone, a verbal order, it is good to speak to 2 nurses. So you speak to the first nurse and you say, this is the order. Then the nurse passes the phone to a second nurse, staff nurse, to asking the doctor to repeat that order to the second nurse. So that there'll be 2 people to confirm that what the doctor gave the order as. Now, I do not know the exact figures of verbal order medication errors. I don't have it offhand, but it does happen. Doctor might want to say give furosemide, but he will say give something else, and both the nurses hear the same thing and they give that because they're following the doctor's orders, and the doctor comes later and says, oh, I didn't order this, I ordered this. So that does happen also. So even 2 nurses listening to the order can still, the doctor can make the wrong call. So we have to be sure if the nurse who is receiving suspects there's something wrong, you can repeat back to the doctor, "Doctor, are you sure you want to give this XYZ drug for this patient?" You know, because you know your patients, we all know our patients. So sometimes the doctor makes a mistake and you can always correct, "Are you sure you want to give this?" So we have to follow some SOPs in the healthcare system.
Thank you very much for the recommendation, Doctor. I strongly agree that we should always have a second person beside us to reconfirm the order, and even we might hear wrongly. So it is always have a second person to reconfirm and to make more, to provide more safety for administrating the medication. So we have another question here for you, Doctor. To save time, nurses prepare injectable medication in several syringes at a time and then label them in advance. Is this a safe practice?
Yes, I know sometimes nurses do that. If it's for one patient, then it's okay because you're going to give all these drugs to one patient. But when I know time is a factor and you say you got a ward full of 30 patients and you want to give the medication, yes, I agree. Nurses do prepare multiple patients at one go. But that is actually not, although you have labeled the syringe and all, sometimes with fatigue, you might just pick up the wrong syringe and give the wrong drug to the wrong patient. It's always advisable to prepare injectables. Each patient has prepared one at a time rather than preparing 5 or 6 at a time. You are bound. 99% of the time you might get away with it, but the 1% you give the wrong medication to the wrong patient and the patient dies or becomes permanently disabled, you will regret it for the rest of your life. So don't try to prepare for multiple patients at one go, especially injection forms. That's my advice.
Thank you, Dr. Ravin. The next question is, what is the advisable rate on giving of calcium gluconate and magnesium sulfate via infusion pump?
Oh, okay.
I believe it's following the order.
You need to follow the protocol of the hospital for what the magnesium sulfate is being given. There is an obstetric practice for PE and all that. You need to give the loading dose over 1 or 2 hours or 4 hours. It depends on the protocol and the dosage you're giving. What is the protocol in your hospital? So you need to follow that. As well as usually then these hospitals develop your protocol, they are looking also from the drug literature, what is to be given over what period of time. So follow whatever the protocol is in your hospital.
I do agree as well, Doctor. It is also based on a patient's condition and the level of the calcium on patient's body. And even I believe that significant changes in ECG will indicate what is the most required at the moment. Yeah.
Yes, I agree.
Yeah.
So just like potassium chloride, if the patient is in the intensive care unit where we monitor the patient ECG and all, and the potassium is low, we can fast correct the potassium. But I won't fast correct the potassium if the patient is in the ward where there's no monitoring. So it depends where the patient is and what kind of monitoring is available to the patient before you look at the rate you want to follow. So that's why hospitals have certain policies, like some hospitals will have the policy that you cannot say give potassium in the ward as a rapid correction, but in the intensive care unit or in the critical care unit where the patient is under continuous monitoring, that is allowed. So it depends on the policy of the hospital.
Agree, Doctor. We have one more question here. We have 2 more questions here. Medication that order for initial dose might not follow the recommended medication serving time. Is there any recommendation of guidelines on next catch-up time for oral and IV medication until the recommended medication serving time?
Actually, this was the example I gave. the medication time is supposed to be at 12 noon, but you are given the first dose at 9 a.m. So the next dose is supposed to be at 3 p.m. Yes, maybe you can give it an hour earlier to slowly catch up to get to your medication timing. But ideally, you need to follow what is recommended by the drug literature to follow actually to the timing of what time you are given the first dose and the subsequent dose. Because don't forget, when you give the dose, it takes time for the body to the level to go up in the blood. And then why they say 6 hours later is because at the end of 6 hours, the level will start dropping. When you give the next dose, it will go up. So, but you're given something at 9 o'clock, and then at 12 o'clock, you're going to give the next dose. You are already overshooting the level which you want to have it in the blood. So you maybe an hour or so you can adjust, but not too much of a variation, because otherwise you have the plateaus and the troughs in the bloodstream.
Okay, the next question, doctor. Doctors are giving verbal order even they are physically in the hospital. Also, it's not emergency situation. Is this a right practice?
Actually, before you give a verbal order, actually you should come and see the patient. Doctor should come and see the patient before giving the verbal order. Because especially in the wards, you can't just give, unless you come and see the patient, you really can notice whether you need to give this drug or you don't need to give the drug. So if you are in the hospital, you should come and see the patient and assess the patient first before giving the drug. I can understand, especially if you're at home, after office hours, you're at home, you can ask your junior doctor to go up and see the patient first before prescribing the medication. Or you can speak to your junior doctor who is on call in the hospital to see the patient first, report back to you, and then follow the orders. It's a not very good practice if you just give over the phone orders, give this and give that when you have not seen the patient. An example which I gave just now was about the furosemide injection. I myself had experience where the nurse rang up and told me there was no urine coming out on a ventilated patient. And I ordered furosemide. And now, half an hour later, I called back to find out, is there any urine? And when the nurse told me, oh, there's no urine. So I came in to check on the patient. And what I found was actually the urinary catheter was kinked. And when I unkinked it, there was a whole lot of urine coming out. So that's why you need to come and see the patient so you know what is wrong with the patient and whether you need to give the drug.
That was a great experience sharing, Doctor. Interesting. In view of time, I will take up this as a last question before we start our second session. Yeah. Do you recommend to have drug preparation done next to patient bed instead in the treatment room? Do you think the concept of standard scheduled drug dispensing time should be abolished in the hospital to ensure patients were given medication at the right intermittent time?
Actually, I would ideally prefer to follow the timing of the drugs rather than having a standard policy in the hospital. Like what I said, TDS is 8, 4, and 12. 6 hourly is 6, 12, 6, 12. Those are the hospital policies to make it easier for the nurses to give drugs as such. Ideally, that is not acceptable. But because of staff shortage, that is a way they have prepared. In regards to preparing, if it's oral medication, usually you can prepare the medications, push the medication trolley to each room and prepare the medication in the room. Injectable drugs, you need a lot of things, there are syringes, so you need to prepare it in a medication room. The drugs are there because you need a few things extra to prepare the drugs. So it depends on whether it's oral or injectables. Injectables can be prepared in the medication room where you have all the facilities there and then take it to the patient to dispense it.
Okay, thank you, Doctor. I will now pass over to you for the next session, our second session, and we will continue with our question and section at the end of this second session. Yeah.
Thank you, Buwa. Okay, we will proceed with my second half of the lecture, where I will be talking about the smart pumps, what is the drug library, and safety measures which we can discuss. Now, the technology in our syringe pumps, infusion pumps have changed over the years. When I started practice way back in 1983, 84, we had these pumps which everything was manual. You had to put the pump, you had to key everything manually. You have to calculate the dosage manually. So if I want to give 3 milligrams per kg body weight to run over 1 hour, I need to calculate how much is 3 milligrams, how many mils I need to run at before I key in the data into the pumps. Or if in the labor room, you want to augment the labor, it's either we count the number of drops, saying 30 drops equals to 1 ml, or that kind of calculations we used to do. But technology has come up so well that we don't have to do these calculations. Everything is programmed into the pump. Okay, so these medication concentrations and infusions are customized into these pumps. There are multiple types, various modules, various companies produce IV pumps, and hospitals provide various pumps, and one pump is different from the other pump, so you will make a lot of mistakes. And the reporting of medication errors relied solely on our direct observation, and it was self-reporting. This is some pictures of some of the pumps from yesteryears and some of the new pumps. The B. Braun pumps were almost 60 years they have been on the market. So they have migrated from simple pumps to very complex, complicated pumps right now. I call them complicated, but I'll explain later. And from manually entering, nowadays you have pumps which got touch screen, alarms, everything built in. The yesteryear's pump, there was no alarm. When the syringe, there's empties in the pump, there's no alarm. So you need to keep track of, this syringe is going to finish in the next half an hour. I need to prepare the next syringe. But today you've got all various alarms on the pumps, which alerts you way before the syringe empties. So these smart pumps, what are they? They are computerized patient infusion devices that include features of administration, error prevention, and data collection to transformational clinical tools that can greatly decrease the rate of IV medication errors in hospitals. This technology provides medication error reduction capabilities via programmed dose limit alerts with audio-visual feedback to staff regarding erroneous disorders, improper dose calculations, and/or programming errors. These smart infusion pumps have been introduced to prevent medication error. The risk of medication errors with infusion pumps is very well established. 22% of events involved a high alert medication, and a majority of wrong rate errors led to medication being infused at a faster rate than intended. And the user programming the pump was the most common contributing factor to this. Infusion pumps are essentially for administering fluid, nutrients, and medication intravenously to patients. However, the use of infusion pumps is also associated with a high frequency of adverse events. So, according to the FDA, medical device manufacturers are required to submit a pre-market notification if they intend to introduce a device into commercial distribution for the first time, or reintroduce a device that will significantly change or modify to the extent that its safety or effectiveness could have been affected. So a serious event is defined as an event, occurrence, or situation involving the clinical care of the patient in a medical facility that results in the death or compromises the patient's safety and results in an unanticipated injury requiring the delivery of additional healthcare services to the patient. An incident is defined as an event occurring or a situation involving the clinical care of a patient in the medical facility which could have injured the patient but did not either cause injury or required the delivery of additional healthcare service to the patient. And high alert medications are defined as drugs that bear a heightened risk of causing significant patient harm when they are used in error, like your adrenaline, your potassium chloride. These are high alert medications. Now, what is a drug library? Before you create a drug library, you need to be done by a multidisciplinary team involving professionals from different hospital departments, from the hospital pharmacy to the different departments where the pumps will be used. Say, for example, this pump is going to be used in the intensive care unit. So you need to involve the anesthesiologist and the nurse managers of the intensive care unit on what drugs you want to be put into the drug library of the pump, what concentration of the drugs to be put in the pump. It differs from if the pump is just going to be used in the ward or in some other part of the hospital, which is not a high critical care unit, where you might have in the pump dosages for running an adrenaline infusion or a noradrenaline infusion. Those may not be there in the pump. So you need to custom make the drug library for where the pump is going to be used. So again, then the department, which department, whether it's going to be in the surgical ward, whether it's going to be in the medical ward or in the labor room. So each department needs to define what drug which is most used in their department and the most sensitive that they want to be included in the infusion pumps libraries. So each hospital will have its own protocol, whether it's using different drugs or using different infusion concentrations, dosage and rates. Therefore, the drug libraries are never the same in each hospital, and they must be designed according to the needs of each hospital, as well as within the hospital, each department. So the drug libraries are specific. You will not have the same drug library in the intensive care as you will have if the pump is being used in the operating theater. So it is different. So you need to sit down with the relevant people to put the drug library in. Medication errors have serious implications. I'm repeating this again to both the patient as well as the healthcare system. It can compromise the patient safety, and because of the medication error, healthcare costs can go up. So what are the factors contributing to a medication error with an infusion pump or a smart pump? The programming. This is incorrect entry of a setting or a value into an infusion pump. The provider may have entered incorrect information for a range of reasons, such as keying in the incorrect patient weight or the incorrect units. So instead of mils per hour, puts milligrams per kg per hour. There's a miscalculation. Or failure to adjust the rate. So you start with the bolus and then you forgot to adjust the rate for after the bolus has entered, what is the maintenance rate? So you might have entered instead of 0.2, you enter 0.2 instead of 0.02. Or instead of 48, you enter instead of 488, you enter 48. Or the most common mistakes is 5 and 50, the one digit difference. So these are the common errors to make on the programming, where the person is going to use the pump, enters the data into the pump. So the other problem could be is you enter a value into the field which is for the volume to be infused. And so you write, so say the volume to be infused is 500 ml, you enter that into the rate field, and then into the volume to be infused, also you enter 500 ml. So the 500 ml will be given within that time. But actually the rate to be in the rate field should have been 50 ml. So a lot of fluid would have gone in a short time. The other common programming error is to choose the correct medication in the drug library. So sometimes in the drug library, you might have the concentration different. You might have adrenaline as 3 milligrams per kg, or adrenaline as 6 milligrams per kg, 6 milligrams per mil. So depending on the, so you might just key in the wrong concentration of the drug. And okay. So the pre-administration process problem, this is the order has been incorrect, the transcription has been incorrect, or the preparation of the medication has been incorrect. So we might have an incorrect medication with the rate and dosage information can be incorrect, or the transcription was misinterpreted based on wrong laboratory test results, leading to a wrong rate and the medication being prepared at a different volume. Now, failure to correctly connect or clamp the IV tubing. Very often, the most common mistake is you set up everything and you forgot to unclamp the IV tubing. Or you might put up the tubing, everything, but you forgot to program the pump and you on the tube, and instead of running through the machine, it goes directly to the patient. Or the tubing is not connected properly to the IV line, and there is a leak at the site of the connection. The other common thing is when you have IV sets going in and you, instead of pushing the IV drip into one and the other one has got medication, you switch the two. So they're all going through an infusion pump, and so the wrong medication is now going through different rates to the patient. Malfunction of the pump. You might have programmed it well, you set it up well, everything is in this correct, but the pump did not function. Okay, I'll give you an example. Is the patient was put on an infusion of furosemide, but you had programmed it, say, for 5 mils per hour. But when you checked, you noticed that actually the pump was delivering more than 5 mils per hour, although your setting everything was correct. So that's a malfunction of the pump. So you should stop using the pump immediately and send it down to your biomedical or checking the pump, or refer it back to the supplier to come and check the pump. Maintenance of device. All these pumps need to be serviced regularly to maintain the pump. So why it needs to be serviced is to prevent it from functioning, to allow it to function as what it was intended to do. The drug library might not have been set up properly. There might be multiple pumps with the same barcode attached. So we have to be careful. So this is the maintenance. If you don't maintain your pump, the calibration can run, and you key in the correct values, again, it will give more or less than what it has intended. So we need to follow the recommendation of the supplier, the manufacturer, to do the maintenance. There are some pumps which need yearly maintenance. There are some pumps which need 6 monthly maintenance. So we need to follow the manufacturer's guideline on this. Patient behavior. The patient may intentionally or unintentionally adjust the programming of a pump. For simple, sometimes the patient is in the ward, we are running the drip through the infusion pump, and somebody comes along and decides, oh, this is a nice gadget, let me play with these buttons, and resets everything up, not knowing what they are doing. See? So this is where the patient's behavior comes away. So either the patient or the patient's relatives who are in the room with the patient adjust the pump settings. So sometimes when the nurse comes in to check over and then she says, oh, why is the rate set, it says 700 mils per hour? It should have been only 100 mils per hour. And then the patient admits, oh yeah, my son or my grandson was playing with the pump and they reset the program. And most of the pumps all have got, the smart pumps have got a locking mechanism. So when you set up the pump and leave it with the patient, you need to lock the pump so that even somebody accidentally presses on the buttons, you will not change the correct settings which has been done. And smart pumps fail. The infusion pump does have problems, the smart pump. It can be a software problem. There can be an error in the alarms. Inadequate user interface design. Like this is mainly a human factor issue. Now, some pumps is so small that as you grow older, you can't see what's written on the wordings of the pump and you make an error in keying in. There can be broken components of the pump, failure of the battery of the pump, the backup battery. It can be due to because the pump was not charged when it was not in use, which is a very common incident. Like when you want to use the pump, transfer a patient from one ward to another ward, but the pump has got no battery because it was not charged. Sometimes water can sprinkle onto the pumps, drip from the drip or other means, which can cause fire or sparks or even shocks to the patient, to the personnel. So, do smart pumps reduce medication errors? So, one of the benefits of using smart pumps was intercepting errors such as the wrong rate, wrong dose, and the setting errors. Other benefits include reduction of adverse drug event rates, practice improvements, and the cost effectiveness. Compliance in using smart pumps is a key towards effectively preventing errors. So when you get a pump, the personnel who is going to use the pump must be taught how to use the pump, how to look for errors, how to set the settings, what is the drug library in the pump, and they need to be taught. And this is an ongoing process. You will have nurses who are there, they might leave the organization, a new nurse might come in. So this must be a continuous process. Give you an example. Years back, I had a nurse who came in. She was just the first week on the job, never used this pump before, and she did not know what to do, and nobody taught her. But she tried to do what she thought was right, but she set it up wrongly. Lucky it was detected and an error was prevented, but the root cause was she was not trained. She should not have been allowed to handle the pump. So anybody handling the pump must be privileged. You must have gone through the training and you need to be compliant in using the pump. If you have not gone through the training, if you've not seen how to use this pump, if you are to use the pump, you should tell, I do not know how to use this pump. Get somebody else who knows how to use the pump and then go for training of how to use the pump and get privilege. The organization should privilege the healthcare personnel to use these pumps. If they're not privileged, they shouldn't be using these pumps. So what are the safety strategies? So the modern infusion pumps, which are also called smart pumps, they have got numerous design features that are intended to prevent various types of errors. Many models of infusion pumps now include the capability of uploading a drug library with preset limits specific to each drug. This drug library technology can help prevent the wrong dose, the wrong rate, and various other setting errors. So you need to ensure an appropriate setup, maintenance of the pump, and the integration of smart pumps. Apply a multidisciplinary approach when evaluating and procuring an infusion pump. So the healthcare organization, when you want to buy a pump, so you need to involve the people who are going to use the pump. Now, given this implication of patient safety and the cost associated with the large procurement of pumps, it is still very important that all relevant parties are involved in the decision-making process, especially the frontline users, like the nurses or the paramedic staff. They should be given the chance to view these pumps, listen to the demonstration of these devices, and in fact have a hands-on experience with this pump before being considered for procurement. You need to listen to the feedback from these frontliners. Because various companies are producing pumps, the cost of the pumps might vary from one company to the other company. As a healthcare organization, as an administrator of a healthcare organization, of course, I will be looking at if pump A is $1,000, pump B is $2,000, I would definitely buy pump A because it's cheaper. I can buy 10 pumps with for pump A compared to only buying 5 pumps. So I get more pumps for the price. But when the frontliner starts using it and they find a lot of flaws, a lot of difficulty using the pump, it is not going to benefit them. And indirectly, it doesn't benefit the management of the organization because you need to buy pumps which is easy to use by the frontliners. So you need to listen to the frontliners and the department who is going to use these pumps. So it is a multidisciplinary approach. So develop a multidisciplinary team and always apply a continuous quality improvement process. This type of process has been shown to produce a range of improvements in healthcare facilities, including those related to the use of infusion pumps. One of the primary components of this procedure is collecting information, which will inform the choice of solutions to be drawn up. So the data, these smart pumps can store a lot of data. You need to review this data and create SOPs from these pump-related concerns. Despite the recent advances in infusion pump technology, hospitals continue to experience medication errors while using infusion pumps. But the data collected will always provide an insight into the frequency of events by stages of medication process, the types of medication errors, and their contributing factors. And you need to analyze this data and come up with policies within your hospital. So there may be many potential solutions to mitigating the risk of medication errors with infusion pumps. The personnel should carefully consider all possible solutions, which will range from acquiring better designed pumps, adjust the settings of the pumps, or develop a more robust error reporting and training program to address these issues. So in an effort to mitigate risks of safety-related events, the personal and healthcare facilities have to foster a strong culture, like I mentioned, a just culture of event reporting, including near-miss events. With that information, a safety program can proactively identify problems and subsequently develop solutions. Targeted and prompt remedial actions, such as training and enforcing existing standard operating procedures to reduce medication errors, should be implemented. So in conclusion, smart pump technology has resulted in improving medication safety, preventing patient harm, faster recognition and response to alarming pumps, and further promoting a culture of safety. Today's smart infusion pumps combines computer technology and drug libraries to limit the potential for dosing errors. So these smart pumps today have a built-in dose error reduction software built into the pumps. Smart pumps use, but they do not eliminate programming errors. The hard limits of the drug library play a main role in intercepting medication errors, but the soft limits are still not as effective as the hard limits because of the high override rates. There must be compliance in using smart pumps, which is key towards effectively preventing errors. The opportunities for improvement include upgrading the drug libraries, developing a standardized drug library for your hospital, decreasing the number of unnecessary warnings, and developing a stronger approach to minimize walkarounds. Smart pumps should be implemented with the idea of using continuous quality improvement processes to literally improve their use. So this is a continuous education going on in the use of smart pumps. So the take-home message is, we are not sure, always return to the basics, the 6 rights of medication administration. The right drug, the right dose, the right route, the right time, the right patient, and documentation of your drug. If the patient tells you it is the wrong medication or treatment, stop immediately and check the order. I think that's all for now. Stay safe, everyone, in this COVID pandemic, and take care of yourself. Thank you very much.
Thank you very much, Dr. Ravin. But still, we have a long list of questions over here. So we are now going to begin the question submitted for the second session. So here we have a very interesting question here. Hello, Dr. Ravin. Do you suggest that the local regulatory medication guidelines should include or recommend the use of dose error reduction system, DERS, in infusion pumps, especially in the ICU or HDU? If yes, how do you suggest we can influence the local regulatory and to make the changes to improve patient safety?
Okay, this is like knocking the door on the politician. All right. Yes, there has to be, these are various ways where computer technology has come in and it is to improve patient safety. So we need to actually try our best to convince the regulatory body that this is important. It's not an easy task. It's always a difficult task when you're trying to convince non-medical people the importance of the safety for the patient and on these pumps. We are using these pumps as much as possible to have safety. That's the most important thing. The bottom line is just safety for the patient. So it is a difficult job. to knock on politicians' doors who are non-medical to try and convince them. This is very important. This program is very important to be included. We must have pumps of this nature. So it is a difficult process. So you need to form a team, do studies, look at international studies, look at international recommendations. What is the going standard for certain pumps, and try and convince your local regulatory body that this is important. Even within the hospital, like I said, as an administrator, I will always look for the cheap pump or a cheap device to use. And because it's cost to the hospital, and my always thinking is, if I put 1,000 ringgit, what is my ROI for this 1,000 ringgit? But we need to convince every step along the way that this is important. Yes, if you have a local regulatory endorsing your recommendation, then it is so much easier. The other way is to maybe go through your local societies, your medical societies, to help in convincing the regulatory board that this needs to be made as a standard device or thing to be implemented. So that way we can get, it will take time, but we will definitely get it. It's just like Malaysia. Years ago, there was no minimum monitoring standards. But over the years, we have managed to convince that for every anesthesia, there must be a minimum monitoring standards, and this has to be implemented. And the government has implemented it. There must be a certain level of minimum monitoring standards. So it is achievable, but it will take time.
Okay, thank you for the answer, Doctor. We have another very interesting question here. Medication calculation in ICU always complex and challenging. In your point of view, Doctor, will this smart pump will completely eliminate these challenges in future?
It will eliminate to quite a bit extent because your drug library is there. So you have already put what the medications you're using in the intensive care into the drug library. And you need to select the correct dosage, what you want to give. And basically all these pumps, you need to put in the patient's weight, patient's height, sex of the patient, age of the patient. So once you key in all this and you select the drug you want to give, you've selected the correct dilution of the drug, then it's much more safer than you doing a manual calculation, trying to calculate the dosage to be given. When you do manual calculation, that's when you tend to make errors, especially, some are in milligrams per kg, some are micrograms per kg. The ampule comes in milligrams, but you need to convert to micrograms to give it as the dosage is in mics per kg per minute, in mics per kg per hour. So there's a lot. That's where confusion takes place. So when you have these drug libraries, everything is already programmed. The algorithm is already in the system. So you just have to key in the drug name and the dosage you have prepared your syringe, key in the patient's height, weight, sex, and age of the patient, and immediately the dosage is there. So it's much easier.
Yes, thank you for the very clear explanation, Doctor. Based on my own experience being an ICU nurse, I think that's the most challenging part when we wanted to calculate the mics per kg per minute, especially during the patient collapse. Or because I was an ICU nurse, and it was really a very tough time for you to calculate and recheck with another person. So I believe this new technology will really help to eliminate, especially this panicking moment. Will be helpful during this panicking moment. So next question, Doctor. What is the significant outcome after changing from using the conventional infusion to smart pump with those error reduction feature?
Personally, yes. There's so much of error reduction when we switched from the ancient pumps, the golden pumps I call them, to this smart handphone pumps I call them now, because everything you can also have programs to look on your handphone what is the rate running and what is technology has just gone so much. Yes, definitely the error rate has dropped, but there is still error, especially in the programming. The incorrect weight is entered or the sex of the patient is not entered. But you see, these modern pumps, these smart pumps are so smart. When you miss one step, say you forgot to key in the weight of the patient, it doesn't allow you to go to the next step until you finish step one. It's just like a computer when you're doing something. And, say you forgot to save and you want to close, it'll pop up there. Are you sure you want to you don't want to save this document or something? So you're very smart. They don't let you go to the next step. Or when you buy something online, you don't key in your credit card number in full, it won't let you go to the next page to go on. And if you have not ticked all the boxes correctly. So that's the beauty of these smart pumps. Rate for error is less, but it does do occur. Especially sometimes what I've seen quite common is when you key in the amount, you want to run 0.2, you key in as 0.02, or the prescription is for 0.02, you key in as 0.2. You forgot to key in an extra decimal point. So these errors still happen. So hopefully one day we will come to a stage where we can also eliminate this kind of programming errors.
Thank you, Doctor. The next question, infusion pump will be classified as a device with clinical alarm during JCI 7th edition survey. Kindly share how would B. Brown involved in training of end user to meet the requirement.
So basically that B. Brown has to go and train everybody.
Exactly, Doctor. Yeah. But I believe that we will definitely be the most supportive company for all the healthcare, because our own tech was we want to have the safety is our ultimate goal of our company as well. So it is a very interesting question, but I would like to add a little bit on that. From your point of view, Doctor, how you believe that training from us will improve, and especially in preventing medication error, meaning to say how effective it will be if there is a support from the device company and merged together with the education department from the hospital. Will this help to promote more quality outcome?
I agree with you, Buva. The device company who manufactured the pump, they know their pump best. They know everything about their pump. When you pass a new pump to me, some basic things I might be able to pick up quickly, but how the pump runs, what is the limitations, what is everything, the best person is the manufacturer. So the manufacturer should spend a lot of time training the personnel, at least maybe a group of personnel in the hospital, to train them first, so that they become the next group of people to teach their other staff in the hospital how to use the pump. But the training from the device company is very, very important. Without them giving us the training, we will not know what the limitations of the pumps, what errors the pump can cause, or how to overcome, how to troubleshoot, we will not know. So the device company must teach the end user about the pump. Once you have taught a group of end users in one hospital, then you can pass on to that group can now teach the rest of the staff in the hospital. But anywhere along the chain of teaching, you need clarification, the device company comes in. It is just like in the intensive care setting, we have turnaround of nurses, new nurses coming in. They might have worked with one ventilator in one hospital, but they come to a new hospital, it's a different brand of ventilator. So they need to be taught. And on and off, there must be days when the device manufacturer sends people in to teach. So it's like a refreshing everybody's memory. It's like compliance. You need to keep teaching and teaching, develop new strategies, see what flaws, what the common medication is, and then go back to the root cause analysis, treat the root cause, and teach people. It's a never-ending process of teaching.
Yes, Doctor, totally agree with you. Learning is forever, I believe. So, Doctor, we have another interesting question here. Obviously, the equipment should be easy to use, but is there any new innovation or updates? Do you think the end user must get the training rather than looking for an old easy way to use the equipment? I believe the question is to ask how much acceptance they have on new innovation and updates from your point.
It is just like I've got an iPhone 6 and now it's iPhone 12. Do I want to change to an iPhone 12? iPhone 15 comes out. Do I want to change? People are changing their phones so regularly because of new technology, new software being built and upgrading. So when there is actually an upgrade of the pump and there are more safety features into a pump, we should actually move forward and go into. It is not, I'm saying we buy a pump today and next year a new pump comes out, or throw this pump and take the new pump. The hospital will throw me out of this hospital because for them is the cost of return, ROI of the pump money spent. But again, today's smart pumps, it's all software. So it's upgrading the software of the pump. The hardware can still be the same, but the software can be upgraded. Things can be developed. And I know there are certain pumps where they keep upgrading the pumps. They just come and upgrade the software with new features, new safety features. So that can be done. And then again, whenever there's an upgrade, there must be teaching again about the upgrade, what it can do, what it cannot do, what are the extra safety features, whatever it is. There must be teaching back to the end user.
Yes, Doctor, I agree with what you say. It always comes back to how the knowledge and the updates are given to the end user. So next question, Doctor. The question is, how often or how long should a pump to be sent for maintenance? I think this is more biomedical.
It's a biomedical question, yes. But it depends on the manufacturers of the pump. Like I said in my lecture, some pumps, the manufacturers recommend a yearly maintenance of the pump. So where the manufacturer comes back in to service the pump, calibrates the pump and make sure the pump is in working order and can be used safely on a patient. Some pumps are 6 monthly. So, but most of today's pumps are yearly maintenance program is there. So that's back to the hospital management that they must make sure these pumps are regularly maintained on the recommendation of the manufacturer. So again, there must be proper logging, proper stickers put on the pump when it is due for the next service or maintenance. During maintenance, if the pump is found to be faulty, manufacturer should take it back, get it repaired and bring it back. Not just leave the pump and say we will send another technician or another person to come and sort out the pump. So it's an ongoing process, but the maintenance must be there on a regular basis.
Thank you, Doctor. Then we have another question here regarding privileging. What is the validity of privileging of using the pump? Is privileging from vendor or manufacturer sufficient?
The privileging should be its process as such. See, the manufacturers will privilege the vendors to teach on the pumps. And the vendors should teach the hospital end users on those pumps. So the hospital can then privilege like this, people are allowed to use the pump. So then the hospital will be training more and more of their staff to use the pump, so they can be privileged to use the pump. So like a new staff coming into the unit will not be privileged to use the pump until she has undergone the training to use the pump. Okay? So whenever there's an upgrade of the pump, again, there should be another privileging exercise done so that the new features of the pump can be, everybody knows about the new features of the pump.
Okay. Doctor, we have another question, a very interesting question here. How do we reduce or make the pump alarms silent as we are heading towards silent ICUs in hospitals?
That's why today's pumps, you can silence the pump inside, but you can hear the sound. So they can be interfaced with your monitoring system. Most of the monitoring systems, they have already got this interface thing where you just connect the pumps onto the monitoring and you can see everything on the slave monitor outside, where then the alarms come on the outside. This is going towards silent ICU as such. So it is the manufacturers of the pumps working hand in hand with the monitoring devices in intensive care, the manufacturers of those. So where they work with each other hand in hand. So that can be done. We have done it in our ICU where pumps are from one company while the monitoring is from another company. They have interfaced and the ICU is silent. So it can be done. It's just the two manufacturers talking to each other.
Okay. Doctor, in view of time, I will take up the last question and we will end the Q&A session after this last question. The last question is, how about messaging via handphone to prevent errors due to the accents or the pronunciation or maybe the abbreviation that's used in phone messages? I think this is quite interesting because we talk about verbal order, but none of us actually talk about messages through phone.
Messages, yeah. I mean, that's a good thing because it's there. You write out the message. It's just like writing out the prescription. But yes, you write out a message and you send. Like I said, sometimes the doctor will say, want to say something but might type in the wrong message, or the spelling might be wrong, or, I don't understand some of the SMSs and messages, WhatsApp message I get is so like short form. I will try to read and think, what is this message the nurse is trying to tell me? So yes, it can be done, but everybody has to be on the same page. They understand what is being said. Again, if the nurse or the caregiver is not sure what is this message, should call back the doctor to double check what has been written is correct, what dosage has been written is correct. See? So yes, a lot of short form messages goes wrong, but sometimes some people might not understand the short form. You tend to use a lot of short forms when you send your WhatsApp messages. So it's a risk there, but it's always safer to double check with the person ordering the drug.
Okay, thank you very much, Dr. Ravin, for a very wonderful session and also being patient to answer all of our questions. I think closely we answered more than 15 questions. We addressed it, and I believe that helps us to understand and get more insights on our smart pumps technologies and how it can prevent medication error. With that, I thank everyone who attending today's webinar, and kindly refer to this our chat box to get your link and passcode to generate your e-certificate, and also do free to provide us your feedback for our future improvement. And also kindly you can just again click the appropriate answer and submit for our feedback for our event today. With that, thank you everyone.
Thank you. Stay safe and bye.
Recording stopped.